So all what you have to know is the three. Shabab, ركزوا معاي. CML, breakfast lymphoma, follicular lymphoma, because it's uncommon. So I want to remember those, and I remember the oncogene. So BCL2, for example, I want to know in follicular lymphoma. CMEC in breakfast lymphoma. BCR is in CML. This one. So this mechanism of is translocation. So translocation is checked by fish technique. خلاص? Any question before I move? Yes.
We have to write
No, only 11 for 18, for 8, 14, 14, 18. Not this number. No.
Why do we have to remember the numbers exactly?
This number translocation here.
From 1
14, 18, but this number, specific number, no. 9, 22, 8, 14, 14, 18.
Why is that important?
Very important so that you know which chromosome is affected. So these are common chromosomes. Because you are going to request it. Follicular lymphoma is sitting here, BCL2. BCL2. So this is in BCL2, follicular lymphoma BCL2, in CML, BCR, and Burkitt's lymphoma CML. Gene amplification, I don't know about this, I missed to put in breast cancer HER2. The typical example of gene amplification is breast cancer HER2. In 20% of breast cancer, there's a gene, I'll show you, we have a slide for that. HER2 has 20% of breast cancer patient, HER2 is amplified. Why I want to remember HER2 amplification? I want to remember these genes because we have medication against them. It's not here. It's not here. I will show it to you in another slide. Gene amplification is a typical example. HER2, HER2. Then in point mutation, so you understood now. In amplification, HER2, HER2. HER2 amplification. And HER2 is present in breast cancer, 20%. And the reason I want to remember these oncogenes, because we have medication against them. This medication is called target therapy. We target them. In 20% of breast cancer, there is amplification of HER2, and those patients will get target therapy, percentage. So that's why I want to remember this. And I'll have slides on that. So, the third example is point mutation. Point mutation, we have oncogenes that will cause abnormal growth factor. I don't want you to remember all this, but the mechanism. As I mentioned to you, growth factor, like platelet growth factor, beta, and so on. We have, then we have receptors, the genes that cause receptors. Then the on-tyrosine kinase genes. So what I want you to remember is the family that affect the receptor is the epidermal growth factor, then the KRAS family, then the BRAF. So the epidermal growth factor receptor. So epidermal growth factor receptor, EGFR. EGFR, I will show it to you now again. EGFR is the receptor. When there is a mutation in that EGFR, no need for growth factor, and it's present in non-adenocarcinoma. 20–30% of non-adenocarcinoma, they have EGFR mutation. EGFR. Point mutation. It's point mutation. All of these are point mutation. Example point mutation. And KRAS in GI cancer, in colon cancer, pancreatic cancer, and lung cancer. KRAS mutation. KRAS mutation. Point mutation. And BRAF mutation in melanoma and thyroid cancer. So three mutations I want to remember.
Where's the
BRAF? KRAS and EGFR. So all of these, so I'll go back. Shabab, let's zoom out. For proto-oncogene to oncogene, we have three mechanisms. The first mechanism is translocation. An example of that. Give me example. Burkitt's lymphoma, the oncogene is involved. CMYC.
Yes.
CMYC. And the other oncogene. Follicular lymphoma, BCL2. And the third one, CML. And the oncogene is PCR. That's
For what?
for CML. The oncogene is PCR. It's called chronic leukemia. So, chronic myeloid leukemia, PCR, follicular lymphoma, BCL2, and Burkitt's lymphoma, CMYC. These are typical example of translocation. Then the other mechanism is amplification. Typical example is and HER2 present in 20% amplified in breast cancer. And the third mechanism is
Point mutation.
And the three oncogenes we are
AGFR, neuromuscular.
yeah, AGFR is lung adenocarcinoma. Lung AGFR and lung 20% lung adenocarcinoma. BRAF in melanoma and thyroid cancer. And KRAS in 90% of pancreatic GR. But it's 90% of lung cancer. Now, why I want to remember those? Because these are important for therapy, or either diagnostic markers, or prognostic marker, or predictive markers. Diagnostic means it helps us in diagnosis. Prognosis, it tells us the outcome of the cancer. Predictive, it tells us if there's a response to therapy or not. That's it. There are three types of molecular markers. Diagnostic, it helps us in diagnosis. Prognostic markers, here it tells us the outcome. And predictive. Predictive like EGFR and HER2, it tells us if there's a mutation or amplification, the patient will respond to targeted therapy. So these are that's what I want to know. These are the any questions so far? Wadah? This is the so but all the rest is your example. No.
KRAS, MRAS,
These are good mutations. شباب ركزوا معي. From proto-oncogene to oncogene, we have three mechanisms. Translocation. Examples. CMYC in what?
in CML.
خلاص واضح؟ then amplification. Typical example.
HER2 in breast cancer.
20% of the cases. And EGFR and point mutation. EGFR in what?
Lung and what?
And KRAS in GI, pancreatic cancer, and lung cancer. And melanoma and thyroid cancer.
If there is mutation, they will respond to the
Why do you guys talk that?
Excuse me, doctor.
This isn't the recording, man.
Excuse me, doctor. The slides, the EGFR is an overexpression.
No, I'm speaking about because this is not good. I'm talking about educational new ones. So
all of these are
void. No, translocation.
Yeah, but no, I'm using EGFR.
KRAS and BRAF.
Yeah, overexpression because of mutation.
Oh, because of point mutation?
Yeah.
Because the slide says sometimes.
All these genes, when they're a translocation, oncogene, okay, you are still confused. When there is oncogene mutation, whether translocation, or point mutation, or amplification, there is overexpression of with all of them, because in oncogene there is activating mutation.
Yeah.
Remember, the oncogene, we need more of the oncogene to push this cell forward. This act, whereas the tumor substance gene is inactivating. We want to stop.
Yes.
Stop?
Yeah. So Professor, when we say point mutation in EGFR, that means it's the DNA that's stimulated by EGFR that's mutated?
the gene, the EGFR, the exons from 9 to 21, they are mutated. The gene has exons, the exons, some of them, 9 or 12, they are mutated. Means there is post-mutation.
They don't need the EGFR. They don't need EGF anymore.
Yeah, they don't. The receptor is mutation always active. Okay. The receptor, because we ask people the receptor, EGFR. The receptor is always active. They don't need the cross-factor.
They don't need EGF.
Yeah, which is the cross-factor. And the mutation is point mutation. So you expect either substitution or deletion or substitution. So it depends. Some cases we have deletion, point mutation. That's it. خلاص واضح? So we move on. Now I want to emphasize this again. شباب ركزوا معي عشان because it's complicated في but I want you to understand it. Yeah.
What do you mean by no legend?
You come there.
Sorry?
They don't know legend.
Sorry, what's the question?
What do you mean by no legend?
Oh, we'll talk about it. I didn't talk about the slide. So we have epidermal growth factor receptor. It's very important. I want to focus on this. These are oncogenes. Of course, these are normal, but when we come to we have 4 of them. EGFR, which is here 1, this is point mutation in lung cancer, as we see. So all these receptors means that when there is a mutation, the receptor is always active. You don't need the growth factor, always active. So in 20% of lung cancer, 20%. There is EGFR. So we have biopsy from lung cancer, we check if the EGFR is mutated or not. If the EGFR is mutated, then we give them target therapy. Same. There are other EGFR. One of them is the HER2 in breast cancer. This one, HER2 in breast cancer. And in HER2, we don't have, the ligand, the growth factor is not known up to now. The ligand is not known. Yeah, it's not known. So we call it orphan receptor. So it's not described yet. So we call it orphan receptor. So the receptor, there must be some growth factor we don't know. So we call it orphan receptor. So one day it will be discovered. Like so all in HER2, what will happen? What type of mechanism?
Amplification.
And in what percent?
20%.
And that's important. So, let me. So, what is the relation to BRCA1 and BRCA2 that I told you yesterday?
One is lung
suppressors. Those are tumor suppressors.
They
So,
are
what's the relation to HER2? No.
That's a loss of function, and this is gain of function.
Let me explain to you. That's why I asked you. BRCA1 and BRCA2 are tumor suppressor genes. That means the patient has the risk of cancer. So it has not those patients the risk of cancer. So the patient and ovarian cancer, breast and ovarian cancer. So the patient comes to us and the BRCA1, BRCA2 is positive. We ask the rest of the family, mother, father, sisters, and so on, check them. So if they are positive, those patients has high risk of cancer. So once they develop the cancer, it's not important now. What's important is the HER2 for the treatment. But most of the breast cancer are sporadic, not familiar. The vast majority, 90%, more than 90% of breast cancer is sporadic. It's not familiar. So the BRCA1 and BRCA2, we don't, when the tumor comes, we don't check the BRCA1 and BRCA2. We check it in the blood for the patient for the risk of breast cancer. So when the patient develops breast cancer, we are checking HER2. Why we are checking HER2? Because for targeted therapy. So all of the breast cancer and all lung cancer, if the patient has lung cancer, we take a piece for molecular study. Molecular study, we are doing what type of study? Point mutation. So we do mutation analysis for EGFR. For HER2, what we do? Amplification study.
But when you say we're checking for BRCA1, BRCA2, you mean mutations of BRCA1, BRCA2, right?
Yeah.
Because the gene itself is normal, it's a tumor suppressor gene.
The tumor suppressor gene.
So it's a normal gene, but then we're checking for mutations.
Similarly
for HER2, we're checking for amplification in this gene.
But we don't, it's BRCA1, BRCA2, we don't check the tumors.
We check
Okay,
BRCA.
we check before.
We check, we don't check the family.
Yeah.